بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اليوم إن شاء الله نتكلم عن موضوع مهم جدا في حالات الهيمودياليسيس أو المرضى الغسيل، خاصة اليونج فيميل in the fertile period. And if you discover your dialysis patient, young female already is pregnant, how you can deal with this female to save her pregnancy till the end of the pregnancy and till the happy day. Today we'll discuss all related issue related to pregnancy and renal disease. Especially I have one case already, we follow this patient already till now for second pregnancy, but I will just tell you the story of the first pregnancy of 2016, and she's now is pregnant, and I think now in 28 weeks now. She's a female patient, around 40 years, is in end-stage renal disease, in home hemodialysis, around 6 times per week. The patient developed end-stage renal disease secondary to focal segmental glomerulosclerosis, biopsy proven. She is pregnant now for second pregnancy for her, and already the first pregnancy passed with full term, healthy boy. And today, just I will mention for you the story of the first pregnancy from last menstrual period till the happy day, as at least to give us multiple lessons in this presentation to how to take care in a pregnant young female in our hemodialysis unit. Just I found this already. This picture slide is very nice. Just for any patient started to be pregnant, you can, if the patient is in ACE or ARB, just to review the medication to stop this medication or the statin, and you should start aspirin after maybe after 2 weeks or 3 weeks or second trimester. Better to start, if you know this patient is pregnant, better to start aspirin at least 81, and you can increase by second trimester to 2 tablets per day until bedtime. Okay. And you should stop at 36 weeks of gestation. And the patient should have a protocol for hair dialysis, as I will mention for our case today, to intensify dialysis for your patient. At least, if no residual renal function, we need more than 36 hours per week. With residual kidney function, adjust treatment, and the blood urea nitrogen should be less than 30 or 35. There's already protocol from Toronto pregnancy and the kidney disease from pregnancy kidney clinic follow-up protocol. Just diet and just protein will be more increased, not 1.2. You can increase to 1.5 to 1.8 gram per kg per day. Don't forget folic acid for any pregnancy test or ultrasound finding of pregnancy during dialysis. Don't forget aspirin, folic acid, increase protein intake, and just try to put protocol for this patient. If you just try to arrange for her dialysis daily as you can. Volume status, we need just for the volume status need ultrasound follow-up, as we mentioned. We need a follow-up maybe every month or every 2 weeks to follow up ultrasound as a facility available in your center. You can do ultrasound every 2 weeks or every month. It's not no side effect for that. To assess cell growth and the pulsatile index. You know, pulsatile index is the uterine artery pressure. Because if this pressure more than 3, it's normal around between 3 to 5. But if more than 3, is the risk for your patient to have resistance in his uterine artery. This may be a risk for preeclampsia. Blood pressure, you should keep your blood pressure less than 140/90. But not less than 100 or 110. Don't treat your patient hypotensive. Just keep less than 140/90. Post H dialysis. Ultrafiltration, you should try to adjust your target weight for your patient according to the growth of ultrasound of your baby, and we will discuss all this in details. We need to be careful on that at regard to target weight. From 1 to 12 weeks of gestation, you can increase 1 to 1.5 kilogram total during this period, and after 12 weeks, you can increase 0.3 or 0.5 kg per week. After 12 weeks, you can increase 0.3 to 0.5 kilogram per week. Take care from that point also. Don't take more fluid. This will affect your PB, your pregnancy, PB pregnancy perfusion like that will affect, maybe will end by hypotension and decrease the perfusion to your placenta and the baby. The target weight, don't forget, from 1 to 12 weeks of gestation, it should increase 1 to 1.5 kilogram in total. After 12 weeks of gestation, just increase 0.3 to 0.5 kilogram per week. Other parameters are the regular dialysis patient, anemia, and calcium, electrolyte, phosphorus, magnesium, and everything. Just an anemia, you need to keep your patient above around goal around 10.5, 11.5. And the last KDO recommendation, just by oral iron if she can tolerate, or IV iron during dialysis better. And to keep the iron saturation around 30 to 50% iron saturation. And the erythropoietin increase regular dose by 50 to 100%. You should increase by 50 to 100% to increase the erythropoietin dose. Dialysis composition, potassium, just keep 3 to 6, just keep, because the patient daily dialysis is better to keep K3, K-pass, don't increase, don't put K2 or K, just K3 is okay. Calcium 1.5, 1.75, you can increase the calcium during the dialysis, not 1.25, better to put 1.5, 1.75. Bicarb 25 is okay because daily dialysis, or 35, no problem, because it will end by hypokalemia at the end. And phosphorus, because daily dialysis, your patient will be hypophosphatemic, you can add fleet enema to dialysate around, we can put either 120 or 60 or 30 according to your patient response, and you need dietitian included in all this scenario to control all this electrolytes. Dietitian, just this summary for this protocol adapted from Toronto Pregnancy and Kidney Disease Pregnancy Clinic. Clinical protocol is that it's a nice clinic, and this case already I adapted from this clinic also. We'll start بسم الله الرحمن الرحيم. الآية المفضلة لنا جميعا. قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. نبدأ بالكيس برزنتيشن. لازم نبدأ بالصلاة والسلام على سيدنا وحبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. توكلنا على الله. ده البروتوكول، لو حد عايز ياخد صورة منه، بحيث لو قابلت أي عيان بريجنانسي في الدياليسيس ممكن تاخد صورة منه وتسمع الفيديو وتشوف إيه اللي بيحصل في الميكانيزم، اللي بيحصل عموما للفيميل during الفيرتيليتي بيريود during the dialysis when the female reach to intestinal disease will impair her fertility. Will start by menstrual irregularity when the estimated GFR less than 15, and amenorrhea will approach when the estimated GFR less than 5 ml per minute, and also anovulation, no ovulation, and menstrual cycle are typically anovulatory. Menopausal is earlier in female patient, maybe around 40s, she can reach to menopausal period. Intestinal disease and barrel fertility during the follicular phase, luteal phase, estradiol and progesterone, increased prolactin, subclinical hypothyroidism. In follicular phase, we have FSH comparable and LH is high, lutein hormone is high, and the luteal phase, you don't have surge for luteal hormone is absent. Estradiol and progesterone extremely low, increase prolactin secondary to decrease the clearance from the kidney, and subclinical hypothyroidism also increase with decrease the GFR. And this mechanism here why our patient not get pregnant or loss in fertility during the hemodialysis, because this low estradiol associated with CKD and intestinal disease inhibit both this gonadotropin releasing hormone pulses. This will end by loss or LH and the focal stimulating hormone surge already will be lost, and this will end by no ovulation, and this is the main mechanism or pathway for infertility, because all this low estradiol associated with CKD and intestinal disease. Our case is the most interesting case I will present today for you, to give you just a light, a small light or a small way, or just a hint to how to can follow any patient you discover during your dialysis. This patient you're pregnant, how you can deal with this patient. And we have this patient already 32 years, started to be pregnant at 2016. I'm going to discuss now what is the scenario happening for this patient. This patient, 32 years old woman, who was seen for initial consult on 2016 March in our GN clinic for assessment of her primary diagnosis In this stage of disease secondary to focal segmental glomerulosclerosis, already biopsy proven. This is a female patient, 32 years, discovered, seen in 2016 our GN clinic for primary diagnosis in the severe disease secondary to focal segmental glomerulosclerosis. She was initially diagnosed in February 2008 when she presented with edema. She's already the first presentation for any patient you should suspect for GN. The patient presented to your clinic by edema, lower limb swelling, and weight gain. She's from 70 to 80, for example, and proteinuria at that time when you check her ACR or 24-hour urine protein, you found 8 grams per day. She had a kidney biopsy which showed focal segmental tip variant. We know tip variant already. I will discuss focal segmental and all GN disease in separate presentation in details. The tip variant is best prognosis, and the collapsing variant is worse prognosis and focal segmental glomerulosclerosis types. Following her diagnosis, she was treated with high dose of prednisone, 50 milligram daily, 1 milligram per kg for 6 months with partial remission. In 2008, she was transferred to other GN doctor who was started to wean her or withdraw her from steroid dose, and she subsequently relapsed on this withdrawal. After that, she left this doctor and was transferred to other doctor. He started tacrolimus CNI for her. She has sustained a partial remission with dual therapy, prednisone and tacrolimus. She subsequently transitioned to cyclosporin due to fluctuating on her tacrol level. Unfortunately, her renal disease continued to progress in 2012. She diagnosed in 2008, and now she is continuing to progress in 2012, and she subsequently preemptive and started to search for transplant at that point before dialysis, and she already did her dialysis, her transplant preemptive. Preemptive means before starting her dialysis. With living a related transplant in 2012 from her husband as a donor, and within 3 days after transplant, he had documented focal segmental recurrence, biochemical and histopathological diagnosis. She was treated with high dose steroid at that time. There was consideration for apheresis or rituximab, but this was not pursued with the NOSA cause. Her renal disease continued to progress. In October 2014, she started in home hemodialysis. 2014 from 2012, started to think for her home hemodialysis, and she has already created a fistula. Not created, she is already wanted to make AV fistula through AV fistula in her left arm. Her dialysis is scheduled in 5 days. هي هيت كرييتد معناها ان انت بتنشئ شيء. هو البشر ما بينشئوا شيء اصلا، اللي بينشئ الاشياء كلها هو الله سبحانه وتعالى. فالواحد ما بيحبش كلمه كرييتد. هتقول لي يعني already did, she did already AV fistula, that's enough. Or went to vascular and did for her AV fistula, no problem, but not created. Creation only from Allah. She has an AV fistula in her left arm. Her dialysis schedule is 5 days a week for 8 hours. She is anuric. We have here is a facility for this home hemodialysis. The patient can be dialyzed daily if he likes. And she is anuric at that time, also in 2014. Her home blood pressure reading 110/70, 140/90 millimeter mercury. Pre-dialysis and pre-dialysis around like this, 110 and 140, and the post-dialysis 110/70 with goal filtration 1.5 to 2 kilograms or to 2 liters. In terms of her renal allograft, she had a transplant nephrectomy also to December 2014 due to persistence high nephrotic range proteinuria and the inability to gain weight in the setting of focal segmental glomerulosclerosis. In terms of her immunosuppression, she was weaned her prednisone to 5 milligram. In terms of pregnancy planning, she has never been pregnant before. Gravida 0, para 0, never pregnancy before. She's having regular menstrual period. You have many females in your hemodialysis. If you ask, especially young female, you will find most of them with regular menstrual period over the last year. What is the surgical medical history? This is already diagnosed GM, focal segmental primary. She is all this biopsy broken 2008, post-transplant 2012, post-transplant nephrectomy 2014. Her active medications is darbepoetin RNS 80 mic each week, calcitriol 0.25 mic 3 times per week, and prednisone 5 milligram daily, riblavit 1 tablet daily, Vinovir 100 milligram IV once weekly. Review her system. She denied nausea, vomiting. There is no uremic symptoms. Family history. She her maternal grandma had breast cancer, and the paternal grandfather had diabetes. There is no history of kidney disease in the family. Sister has rheumatoid arthritis. Her mother had 5 miscarriages, both early and late, cause of which unknown. Social history, she is married and works as a teacher. She does not smoke, just minimal alcohol intake, 1 drink per week, no drug abuse. Vital sign, I think is vitally stable, target weight 78.2 kilograms, heart rate 73, GVB 2 centimeter above sternal anchor, the examination is normal, respiratory is okay, abdominal examination are remarkable, and she has no lower limb edema with good peripheral pulsation. And current lab medication, most recent creatinine 500, and the most recent albumin 42, and other lab and biochemistry, I think, stable, except this hemoglobin already here, 130, and the patient on darbepoetin and Vinovir, and all stable darbepoetin for her. She's a 32 years old female, assessment intestinal disease, secondary to focal segmental, in summary, 32-year female intestinal disease, secondary focal segmental glomerulosclerosis. Her course of her focal segmental had been progressive and aggressive with end-stage renal disease occurring 4 years after diagnosis. Her renal transplant, which had failed, was also due to disease recurrence. Already transplanted already in 2012 and failed already in 2014, secondary to recurrence early post-transplant. She is now anuric on intensive home hemodialysis with nearly 40 hours of dialysis per week. Our target if patient anuric 36 hours, this patient on 40 hours already. In terms of her pregnancy planning, her blood pressure is controlled. She's undergoing already under intensive hemodialysis, home hemodialysis, her immunosuppression slowly being weaned. Now only prednisone, and already the prednisone is safe during the pregnancy, and this would not be a contraindication towards the pregnancy. And overall, I think she's quite good candidate to trial of pregnancy on hemodialysis. We did discuss risk in details. She was made aware that these are a high-risk pregnancy. Any pregnancy during dialysis is a high-risk pregnancy. We reviewed the current live birth rate that exceed around 85%. She can get a live birth rate, as well as a potential complication include risk of prematurity, secondary to either preeclampsia or cervical incompetence, which we have been in our patient. We discussed their theoretical risk for sensitization if she was to proceed to transplant. So we will ensure she on adequate folic acid. On follow-up, her blood pressure at the target today, but she had been within normal range at home. She did her dialysis regularly. She is 2 days late for her period now. Her menstrual cycle now delayed, and she's usually in time, her period. If she does not get her period in next week, she will complete a serum pregnancy test. She is currently on folic acid 5 milligram daily and the PregFeed tablet. This is multivitamin for pregnancy. Her thyroid is within a good range. Continue with intensive dialysis. Pregnancy test already came positive, and after 1 week, and the folic acid already the patient on hold the RNS because the hemoglobin, if you remember, 13. And repeat CBCR restore and with pregnancy test beta human gonadotropin hormone test. With already will repeat it next week also. Continue to intensive hair hemodialysis. With when you see any patient now start with pregnancy on dialysis. She is doing home hemodialysis 50 hours a week via hair AV fistula, 8 hours daily, 8 hours daily, 6 times per week, 6 days per week. Take care from this message. You can take copy now. She's doing a home hemodialysis, or you can do in your center. It is available at least 36 or 40 or 50 hours per week, 8 hours each day for 6 days a week. Her target weight 72.5, blood pressure is okay. Pre-dialysis and post-dialysis, no lower lymphedema or swelling or short of breath, salt filtration just 1.5 to 2 liter. She has been overall doing well. Her appetite got no nausea, no vomiting. Her RN has been held for 2 weeks due to rise in hemoglobin range around 30. Don't forget obstetric ultrasound regular, maybe every 2 weeks at least, to check the fetus and the growth and the pulsatile index, and they will give you the hint. Each time you should look for pulsatile index and the centile growth for your baby, and the patient steady growth or no for your baby in ultrasound and size and the weight also. And you should follow this lab maybe every 2 weeks to 1 month according to the facility. We need urea as high, as low as you can, because if your urea is high, as we discussed before in our presentation in polyuria, urea is high, the cause of osmotic diuresis, and will let your baby more being more urinating, and this will end by polyhydramnios. Take care from this. So the issue for urea, we need the urea less than 35, as we mentioned, the BUN less than 35 urea, or urea less than 8 or 7.5 if urea, and the BUN less than 35, please, because if high urea or BUN, this will end by osmotic diuresis and will end by polyhydramnios in our babies. Albumin is okay, sodium, potassium chloride, bicarb, calcium, and phosphorus, and BTH, hemoglobin. You should follow up the hemoglobin, keep your anemia around target all during the pregnancy. With the patient, keep iron saturation already in our target. As we mentioned, iron saturation from 30 to 50%, and hemoglobin from 10.5 to 11.5. The recommendation, guidelines recommendation already. And for follow-up recommendation, increase dietary phosphate. Take care, because the patient daily dialysis she will be hypophosphatemia, and the lab assessment maybe every 2 to 4 weeks according to your facility in your center. We already, if you have some center doing every month a regular patient, you should do in pregnancy every 2 weeks better. Yeah. Consider aspirin. Don't forget aspirin, 1 tablet or 2 tablets at the bedtime, and follow up monthly for this patient. If the patient at home, hemodialysis. If the patient dialysis in your center, you will follow daily, no problem. She continued to be on dialysis for 8 hours, 6 days a week. And the blood pressure target weight as a target, and the iron already IV 100 every other session, according to, because the hemoglobin is high, and will follow CBC. If the hemoglobin start to drop below our target, just will resume her iron to increase the frequency of iron and resume her DARB routine. And now her medication started methyl dopa, because the blood pressure started to be raised up after the dialysis to reach up on 40, 150, started methyl dopa 250 BID and increased to 500 BID according to your assessment each dialysis. The first medication started now, methyl dopa. And if you here, iron 100 milligram every week now, because the hemoglobin start to be laid down, and riblavit, don't forget, like Bricfeed, this is multivitamin. And darbutin started again once per week, because the hemoglobin I think dropped to 8 or 9 suddenly. Calcitriol, don't forget this calcitriol 0.25 once daily. Folic acid is the main treatment in pregnancy. Don't forget all this. List for pregnancy lady, multivitamin and folic acid and aspirin. Don't forget all this medication. And the obstetric ultrasound at 12 weeks, 60 days already done. What will see? Just will see growth. Centile for this patient, the pulsatile index not mentioned here, but I told you just will follow each time that appropriate for gestational age. We need to be sure our baby already appropriate for gestational age and his growth or no, in his or her growth or no. Just will follow centile growth each time and the pulsatile index. This lab already will have frequent lab, you know, the hemoglobin here drop to 10. This 100 gram per liter or 10 gram per deciliter. The hemoglobin from 13. So resume the iron and the Venovir for her. Other electrolyte I think is normal. Phosphorus is okay. Potassium is okay, is a little bit high. We should control this, but the most important phosphorus, take care from phosphorus, anemia, and calcium. Creatine is okay. And the ferritin already is okay. Saturation 25% is okay. She's currently in 16 weeks now and 1 day. She's stable on dialysis. She's dialyzed 60 days per week, 8 hours. Her blood pressure, blood flow rate around 300 ml, alpha filtration 2.2 liter, target weight 75 to increase already. You know, her target weight as a start 72 point something, and now increased to 75, 76. At our first slide presentation, as we mentioned, will increase gradually target weight in the first trimester and the second trimester, according to the protocol. Target weight, the target blood pressure is already controlled by methyl dopa or aldomet. Hemoglobin decrease, iron are adequate, and RNS was increased again. On physical examination, you should examine your patient for chest, heart, lower limb for edema or no. And the lab here, the hemoglobin started to be a little bit increased, and the other parameter is okay also. She's now, she's seen again in next visit. She's tolerating dialysis as well, but her urea on higher side. I wonder that was dialysis flow rate. Just if urea is high, just check the dialysis flow rate and recirculation. You can do test for recirculation. It's easy to be done by nurse during the dialysis, because this improve her clearance, because the urea, as I told you, will make osmotic diuresis in her baby and will complicated by polyhydramnios. Blood pressure slightly above the target. We added Adalat. Second line of treatment now, methyl dopa, then Adalat. Her hemoglobin improved and iron store are adequate now. IV iron weekly. BTH is elevated. I think she also need a higher dose of vitamin D, calcitriol. We increase the dose already. Her blood pressure like this, so we increase Adalat for her. Other examination is normal. We recommend assess daily flow, blood flow rate and increase calcitriol. Start Adalat for her, 20 milligram daily, and follow up in 2 weeks with repeat lab assessment. Now, active medication, nifedipine and folic acid and gunavir and riblavit and calcitriol. All this was methyl dopa. The most recent lab again, potassium is okay now. And just done 24-hour urine protein. I think it's done. Just try to collect this. I think this is not accurate because our patient just around total maybe 24 hours, maybe around 400, 300 urine. But it's not accurate, but already this patient was nephrotic range still. And bicarb is okay. Calcium, phosphorus, BTH, hemoglobin already 10.4. Or 104 gram per liter or 10.4 gram per deciliter, and as a parameter is okay. Iron saturation 36%. Assessment, she is currently 20 weeks now. Since her last visit, she has been well. Appetite is good, energy reasonable. She's on home hemodialysis 6 nights per week, 8 hours tolerating dialysis. Her blood pressure in range 140 to 150, over 90 to 110. And here after dialysis blood pressure 110, 130, I think is controlled now by Adalat. She had no lower limb swelling. Her post-dialysis blood pressure on target, hemoglobin at target, calcium profile, metabolic indices all on the target. And with physical examination, vital sign post-dialysis is okay. Active medication, we increase labetalol for her. We started by methyl dopa, then Adalat, now labetalol, because starting need more anti-hypertensive medication to be controlled. We started labetalol 100 BID twice daily, folic acid again, folivir, and riblavit, and the RNS, and the calcitriol. I give you all different scenario happen in here regular visit. And each time we increase some medication to control the blood pressure, just anemia, and to control BTH and others. Obstetric ultrasound, she had an obstetric ultrasound done, which showed normal fetal heart spine around 20 weeks. And her lab again is okay. Everything is under control. Her hemoglobin now increased to 11 gram per deciliter or 1100 gram per liter. And the saturation 36 again, saturated well. She's currently now 27 weeks in next visit, and her continue regular dialysis 6 nights per week, and her body weight now from 72, now 79, 79.5. We adjust her target weight according to the protocol, because we need to, because the baby is growing, and you should keep your patient, don't take more fluid, and if the blood pressure still is high, I know it's volume, maybe volume related, just controlled by antihypertensive medications, with no symptoms of fluid overload. Her blood pressure has been controlled. Post-dialysis blood pressure like this. In here 3 medication, methyl dopa and adalat and lipitalol. Here pre-dialysis reading like that and post-dialysis like that. And just the ultrafiltration, just typically taking 2 liter maximum 2 liter. She's now 60 ml phosphate fleet enema onto, just putting this fleet enema on a dialysate to control her hypophosphatemia and K2 pass, because her potassium above 5 or most of the time. We keep K2 pass for her. She was well dialyzed, her hemoglobin, everything is stable, and IV iron RNS injection, her blood pressure at target, heart rate is okay, examination is okay, recommendation adjust iron increase to 100 weekly, active medication again, all this beside the antihypertensive medication. And the obstetric ultrasound already done in 27 weeks. We'll see this percentile of gross. You should increase the every dialysis from 50 percentile, from 40 before, from 30 before, like that. And the pulsatile index, you should see your pulsatile index less than 3 as you can. Otherwise, this patient will be high risk for preeclampsia if more than 3. Most recent lab, I think everything is okay. Sodium, potassium chloride, bicarb, calcium, phosphorus, PTH, hemoglobin already, 10.8 gram per deciliter. Other lab is okay, and the ferritin is okay. She's now reached 29 weeks. Everything is okay. Dialysis 6 days per week, 8 hours. Otherwise, everything is okay. Blood pressure a little bit higher pre-dialysis, and after dialysis control, dose ultrafiltration 1.8 to 2 liter, K2 pass, fleet enema for hypophosphatemia, 90 ml on dialysate, and everything 29 weeks now. Take care. And her medication plus antihypertensive medication just to increase the fleet enema from 60 to 90. Obstetric ultrasound 29 weeks, 5 days now with pulsatile here, yes, umbilical artery or pulsatile index. For this are with the indication just for resistance in the placental arteries and spiral arteries. With the indication for early signs of preeclampsia, just pulsatile index if less than 3, that's okay. Now 0.8, that's perfect. And you should see the centile here, 62 from 50 before. This you should look for these two percentile with for sign for BB cross and this pulsatile index for preeclampsia. You should follow that. And I put it for you here, pulsatility index. By Doppler already ultrasound for BB, this pulsatility index is peak systolic flow velocity minus in the diastolic velocity divided by mean velocity. And this will give you if less than 3 is good, if more than 3 means iris is target here between 3 and 5. But if less than 3, that's okay. If you start to increase above 3, this will give you suspicion of development placental bed spiral arteries in the pregnancy complicated by hypertension and fetal growth retardation. You know what you will see in an ultrasound of a pregnancy lady in your hemodialysis, this pulsatility index, this reflects deficient and developed placental bed spiral arteries in pregnancy complicated by hypertension and fetal growth retardation. Take care from this point, and I will follow what I will follow in an ultrasound during maybe 2 weeks or months. Just will follow this percentile. Take care from this percentile index with 62%. If this increases, you should follow this each ultrasound. It should be more. The sign of fetal growth and pulsatile index should be less than 3. If more than 3 is the risk for this. As I mentioned, the risk for hypertension and growth retardation. From deficient of developmental placental bed spiral arteries in pregnancy complicated by hypertension and fetal growth retardation. There's the benefit from ultrasound follow-up also, like in lab. Their hemoglobin here is 97 again, maybe from this frequent other electrolyte is normal, but hemoglobin here, but saturation is still okay. She's currently 33 weeks now. She's doing well and tolerating dialysis well. Her blood pressure at target. Hemoglobin being trending down to 297. Her ferritin at adequate. 275 will increase her RNS. Phosphate post-dialysis is on target. We can further increase also her calcitriol, increase RNS to 100 from 80 per week, and calcitriol 0.5 microgram daily, and follow up in 2 weeks with repeated lab assessment. Active medication, all this plus antihypertensive medication as mentioned before, we increase now this and this also. every week, and calcitriol increase for control PTH. Hemoglobin in next dialysis 11.7. I know الأرانيزم والدربابوتين is perfect in controlling and raising anemia in hemodialysis patient or hemoglobin to be rapidly reach to your target. If you have one patient is anemia and waiting for kidney transplant, just give him RNS. Give him high dose as can he tolerate, and you will see a result after 1 week or 2 weeks maximum. You will reach your target, what you need, okay? Focal segmental is a pathological lesion, is not a diagnosis. Just a pathological lesion, not a diagnosis for a disease. Just like here, the focal segmental sclerosis, focal segmental sclerosis here, as we see. That's what we will see in electron microscopy. This is a common question. Focal segmental colonoscopy is just effacement of the process of body sites, lead to nephrotic syndrome, most common in adult. Focal segmental in pregnancy, it's possible. This from Dr. Michelle already. Slides. This is possible for a mother with focal segmental to deliver a healthy baby. However, there are special precautions that must be taken, and the pregnancy should discuss for ahead with your nephrologist. Your nephrologist know you and can help you make a decision that is based on your special health of a medication change also needed to get you into optimal state of pregnancy. Consultation with an OB/GYN or manage a high-risk pregnancy is also helpful. Today we will discuss fertility concern and pregnancy, as we mentioned before, how pregnancy can affect you and affecting how focal segmental can affect your baby, and the dialysis and pregnancy, transplant and the pregnancy also. Pregnancy and kidney disease, there are many things to consider. You and your doctor should discuss them all very carefully. Some things that can affect healthy pregnancy include your age. According to your age, don't give me 45 or 50 years. This is high-risk pregnancy. Based on the current medication, you should know what is the medication important for your life, and protein in your urine, how much proteinuria, and your stage of kidney disease, and the blood pressure is controlled or no. Having other health conditions including diabetes, obesity, this also will be deteriorated during the pregnancy. And this condition must also be well managed prior to pregnancy. Pregnancy counseling must be individualized, getting optimized for a pregnancy take a time. Fertility and the focal segmental. Focal segmental does not itself impact fertility, but there are a number of factors that can which include your age. Fertility decline slowly after age of 30. Fertility will be down past and the current medication cyclophosphamide damage your ovarian reserve. Age and dose and route related can affect the male fertility. Your stage of kidney disease, advanced stage of kidney disease, impaired fertility, reversed by intensive dialysis or transplant. Fertility consultation may be needed if it's unlikely that fertility drugs affect focal segmental, but data is limited. How can pregnancy affect the mother? The disease can flare if you are in remission, but we have no data on likelihood of this happening either before or after transplantation. Proteinuria can worsen if you are on partial remission. Kidney function can deteriorate. Blood pressure can also become more difficult to control during the pregnancy, but most of the pregnancy pass safely and with remission already during the pregnancy. We don't know related to vasodilatation we don't know from more hormonal release during the pregnancy. We don't know. Most of the patient will be with good blood pressure control, proteinuria control during the pregnancy, and the blood pressure under control also. Goal of stabilization prior to pregnancy, manage proteinuria and the blood pressure with pregnancy safe immunosuppression and the pregnancy safe blood pressure medication, like prednisone and azathioprine and the safe antihypertensive medication. What is the safe medication during pregnancy? Safe medication immunosuppression like prednisone may be associated with preterm. This is a complication of preterm birth. Imuran, azathioprine, also safe medication. Cyclosporin, tacrolimus, safe medication may be associated with high rate of hypertension and preeclampsia. Side effects two more are the same of outside of the pregnancy, the same side effect. Unsafe medication, MMF Salcedo, will have this teratogenicity. Already we know that. Cyclophosphamide, cytoxan already. Rituximab also have side effect during the pregnancy. Rituximab will end by beta cell depletion to your baby and high risk for infection. Abatacept and the Cathargel don't have experience with this medication. Other safe medication during pregnancy, misaildopa, labetalol, nifedipine, hydralazine, all this antihypertensive medication is safe. And safe medication, beta blocker, ACE or ARBs, directly inhibitor should be stopped before conception already. Breastfeeding is possible and encourage. Safe medication, immunosuppression, and the blood pressure medications that are safe in pregnancy are also safe in breastfeeding, along with some other selected RAS blockades like enalapril. Enalapril, don't forget, enalapril is safe during the breastfeeding. If your patient hypertensive or preeclampsia and you need to continue her medication after delivery, enalapril 5 to 10 milligram as you, and rituximab, abatacept is also high risk for infection and not much studied. How can the focal segmental affect your baby? Rate of miscarriage in focal segmental is unknown. Pregnancy complications are more common in all forms of kidney disease, including the focal segmental. Including what is the complication will be happening, preeclampsia is most common, preterm delivery, and the small babies. You should discuss all this with your patient and the husband of your patient, modified by your degree of renal dysfunction, level of proteinuria, blood pressure control, other medical conditions including diabetes and obesity. All this will deteriorate your kidney function and the proteinuria during the pregnancy. Transplant and pregnancy. Pregnancy can occur after transplant after 1 year better or 2 years best. A kidney transplant often restore fertility. Pregnancy planning can start after 1 year post transplant, but the best after 2 years if you can. Potential risk of recurrence post kidney transplant is unknown. For summary, for our case, pregnancy is possible with focal segmental glomerulosclerosis, but you need to work with an expert team to make it safe for both mother and her baby. Okay, pregnancy is possible with focal segmental and the patient on dialysis and decisional disease, but you need to work with an expert team, a nephrologist, obstetric, and whatever endocrinology to make it safe for both mother and her baby. I need to mention for you some UK clinical practice guidelines on pregnancy and renal disease, medication in pregnancy, and lactation. This is a nice, just a rapid review for what is the UK clinical practice guidelines on pregnancy and renal disease medication in pregnancy and lactation. Medication, low dose of aspirin, we recommended just 81 milligram. You can take 2 tablets at a bedtime is better. Low molecular weight heparin if your patient needed. If your patient with like nephrotic range of proteinuria and less than 30 or less than 25 as the last guidelines, you can use low molecular weight heparin, labetalol, safe medication, and nifedipine, safe medication for hypertension, misaildopa, prednisone, safe medication, azathioprine, safe, C9, isocyclosporin, tacrolimus, safe medication, and hydroxychloroquine are safe for use in pregnancy, especially with lupus nephritis patient. Concentration of calcium urine inhibitor tacrolimus cyclosporin are checked throughout the pregnancy and immediately postpartum as the blood concentration may change. Medication which interfere with calcium is like erythromycin and the clarithromycin are avoided in the pregnancy and the postpartum. Don't take any medication except by nephrology, or avoided in pregnancy and postpartum. A woman taking tacrolimus cyclosporin whenever possible. Mycophenolate is nephrotoxic, teratogenic, should be avoided. Methotrexate also and cyclophosphamide are not taken in pregnancy as they are teratogenic. Mycophenolate should be stopped before pregnancy, as the use in pregnancy is associated with increased risk of spontaneous miscarriage and fetal abnormalities and teratogenicity. 3 months interval is advised before conception to stop MMF or myfortic. Mycophenolate or myfortic, whatever, MMF or myfortic, 3 months interval should be stopped 3 months before conception planning to allow conversion to safe pregnancy alternative and to ensure stable disease and kidney function, and we can resume this MMF by azathioprine or in urine. Rituximab is avoided in pregnancy due to risk of neonatal B-cell depletion and unknown long-term outcome and high risk for infection after that. sirolimus and everolimus are avoided in pregnancy due to insufficient safety data for that sirolimus and everolimus. Benefit of eculizumab in pregnancy for organ-threatening disease are likely to outweigh risk-benefit with the patient and the pregnancy and the baby. Metformin can be used in pregnancy for women with a pre-pregnancy estimated GFR more than 30 and stable kidney function during the pregnancy. Women can be breastfeeding while taking prednisone, hydroxychloroquine, and azathioprine, cyclosporin, tacrolimus, enalapril, captopril, amlodipine, nifedipine, labetalol, atenolol, and low molecular weight heparin. You can continue breastfeeding while your patient taking all this medication. Contraception safe and effective contraception is afforded to women with reproductive age who are taking teratogenic medication, have active gene or within 1 year of renal transplant or acute graft rejection, and for any woman who does not wish to conceive. This safe and effective contraception should be offered for your pregnancy. Progesterone only pills, a progesterone subdermal implant, and the progesterone intrauterine system are safe. Progesterone, the best one safe now for your patient, and effective contraception for women with CKD. Progesterone only emergency contraception is safe for women with CKD. Progesterone, the best one now. As regards cyclophosphamide, fertility preservation is considered for women of reproductive age who require treatment with cyclophosphamide. Women who have had previous treatment with cyclophosphamide have early investigation of infertility. Multidisciplinary team, women with CKD considering pregnancy are offered pre-pregnancy counseling by multidisciplinary, including consultant obstetric, nephrologist, and expert physician. CKD and complication in pregnancy. Women with CKD are advised there is an increased risk of complication of pregnancy, including preeclampsia, preterm birth, fetal growth restriction, and neonatal unit admission, and that they are more likely require cesarean delivery. You should discuss all this: complication, preeclampsia, preterm birth, fetal growth retardation, and you maybe need neonatal ICU admission after or cesarean section delivery. Inheritable renal disease. Women with known or suspected inheritable renal disease are offered genetic counseling, including inheritance risk, prognosis, and intervention option, including pre-implantation genetic diagnosis. You should also multidisciplinary team and discuss all genetic counseling for risk, prognosis, intervention, and diagnosis. Pre-pregnancy counseling for optimization of maternal and neonatal outcome in women with CKD, which may include stabilizing disease activity, optimizing the blood pressure control, optimizing blood sugar control, minimizing the risk of exposure for teratogenic medication, making a treatment plan in event of hyperemesis or disease exacerbation or lapsing during pregnancy. You should all do all this counseling, stabilizing your disease activity. You should do especially systemic lupus or transplant, optimizing your blood pressure control before pregnancy, optimizing blood sugar control with endocrinologist, and minimizing the risk of exposure to teratogenic medication. And what is if your disease is flared during pregnancy, what is our strategy to treat this flaring? ACE or ARBs, women with CKD or taking just either ACE or ARBs should be discontinued or conversion to other safe medication during the pregnancy. Any ACE or ARBs should be discontinued during the pregnancy. Diabetes screen, pregnant woman is taking prednisone. You should follow her hemoglobin A1C, H visit, and blood sugar also. Women with CKD are over low a dose of aspirin, as we mentioned before, to avoid the risk of preeclampsia. Hypertension, the target blood pressure during the pregnancy for women with CKD is less than 130/80 or 135/85 is the best or less, which should be documented in women the healthcare record. Antihypertensive treatment in women with CKD is continuing pregnancy unless historic blood pressure less than 110 or symptomatic hypotension, and the historic less than 70. You should adjust your medication. Just this picture I found already. This is a nice picture also. Gestational hypertension, if more than 140 and onset more than 20 weeks, less than 20 weeks of gestation, and the blood pressure more than 140. More than 20 weeks with blood pressure more than 190, 140/90, and with new onset of proteinuria, creatinine increase, thrombocytopenia, elevated liver enzymes, pulmonary edema, cerebral or visual symptoms. This will be toxidrome of preeclampsia, and if the patient develops seizure with this preeclampsia symptoms, this means eclampsia. Hypertension, just labetalol. We'll discuss this hypertension in pregnancy in one separate presentation also. Don't forget that. Labetalol, I already prepare one presentation for that. بس ادعوا لي بالوقت بس ان شاء الله نقدم لكم المزيد. Hypertension, we have labetalol, nifedipine, methyl dopa. This is a safe medication, can be used to treat hypertension in pregnancy. ACE or ARB should be not used during the pregnancy. Who can use after delivery? Enalapril. Don't forget enalapril, 5 mg or 10 mg. Preeclampsia diagnosis superimposed. Preeclampsia is considered in women with a non-proteinuric CKD if she develop a new hypertension, blood pressure more than 140 systolic and diastolic more than 90 with proteinuria, urine PCR more than 30 mg per millimole or ACR more than 8 mg per millimole, or maternal organ dysfunction after 20 weeks of gestation. In women with proteinuric CKD, if she developed new hypertension more than 140/90 after 20 weeks of gestation. In women with chronic hypertension and proteinuria, if she developed maternal organ dysfunction after 20 weeks of gestation. This is a different definition for preeclampsia or diagnosis. You suspect preeclampsia for any of this situation, either non-proteinuric CKD or proteinuric CKD or chronic hypertension with proteinuria, all after 20 weeks. With blood pressure more than 140/90. Risk factor for preeclampsia: history of AKI, kidney donor, kidney transplant, chronic hypertension, CKD patient, all this, and even old age also is risk. Chronic hypertension lead to preeclampsia in women with chronic hypertension and proteinuria. That's the development of sustained severe hypertension, systolic blood pressure more than 140 and or 160, and the blood or diastolic more than 110 or doubling. Antihypertensive medication or substantial rise in the proteinuria, doubling the urine PCR, ACR compared to early pregnancy showed prompt clinical symptoms of superimposed preeclampsia. If chronic hypertension and superimposed preeclampsia, blood pressure is too high, and doubling the antihypertensive medication, doubling the PCR, ACR, all this will just put in your mind maybe superimposed preeclampsia and this chronic hypertension. We have this test already used, the soluble FLT1 divided by this placental growth factor ratio to just diagnose the preeclampsia before symptoms to occur. Early diagnosis for preeclampsia by this ratio. This is already done in our pregnancy clinic, especially in CKD clinic with pregnancy. This soluble FLT1 or soluble FMS like tyrosine kinase 1 divided by placental growth factor. Soluble FLT1 divided by placental growth factor. This ratio should be less than 38. If more than 38 or more than 40, this is mild preeclampsia. If more than 80, is severe preeclampsia. Don't forget this test. If you can do, you better to do. If you suspect your patient hypertension uncontrolled, you can do this test to diagnose your patient preeclampsia or not. With the placental growth factor plus or minus soluble FLT1 factors. This to diagnose superimposed preeclampsia dependent on the ongoing research in women with CKD. And the diagram. Don't forget take a picture for this. If you will do this test, a soluble FLT1 divided by placental growth factor ratio. If less than 38, no preeclampsia. If more than 38 to 85, this mild preeclampsia. If more than 85, this severe preeclampsia. The best test if you suspect your patient preeclampsia, if you can send this, whatever the price, to at least to guide you, your patient will go to preeclampsia or no, or not preeclampsia, or just a chronic hypertension. Okay, don't forget this. Soluble FLT1 divided by placental growth factor. If more than 85, the severe preeclampsia. Less than 38, no preeclampsia. In between, this mild preeclampsia. Proteinuria, woman with nephrotic range proteinuria. The patient should be over thromboprophylactic low molecular weight heparin. You should, if the patient with severe nephrotic range proteinuria, no clinic membranous, or whatever minimally changed disease or diabetes, and now is pregnant 26 weeks or 30 weeks with severe nephrotic range proteinuria, you should overload those low molecular weight heparin as prophylaxis during the pregnancy. to avoid any pulmonary embolism and the risk of DVT and then pulmonary embolism. Non-nephrotic angioproteinuria in pregnancy is a risk factor for thrombosis and thromboprophylaxis with low molecular weight heparin should be considered in presence of additional other risk factor, obesity like that. Proteinuria is the most common cause of new onset nephrotic angioproteinuria in pregnancy is preeclampsia. Preeclampsia is the most common cause of new onset proteinuria in pregnancy, which one of the possible cause of proteinuria postpartum or of the above. Expected residual preeclampsia, expected progression of diabetic nephropathy if you are patient diabetes, expected progression of CKD or new onset AKI or none of the above. I think all of the above, maybe anyone from the above. When should proteinuria disappear postpartum following preeclampsia? Proteinuria from preeclampsia can last longer than 1 year postpartum, maybe 1 year or more. If proteinuria disappear post, don't be hurry. Resolution of hypertension and proteinuria postpartum in preeclampsia. Resolution of hypertension and proteinuria depends on the severity at the time of the disease. If severe hypertension, severe nephrotic angioproteinuria, will take long time to be recovered. AKI with TMA, that's a typical presentation we can discuss also in a typical presentation. Just the differential diagnosis, AKI, if you suspect this patient maybe with thrombocytopenia and elevated liver enzyme like that. What is the differential diagnosis in AKI in pregnancy, whatever? The most important, don't forget TMA, but septic abortion can be one cause, hyperemesis and sepsis postpartum and pregnancy-induced hypertension, eclampsia, DIC, HELP syndrome, placenta previa, rupture of placenta, postpartum hemorrhage, hemolytic uremic syndrome. The most important, don't forget, retained product of conception and sepsis, urinary tract infection, septicemia. Don't forget all these causes of AKI post in pregnancy. And then postpartum, don't forget any patient with AKI postpartum and residual AKI. Don't forget this TMA, the most common one is TMA post-pregnant and the hemolytic uremic syndrome also. And then during the pregnancy, during this period, weeks of pregnancy here, abruption of placenta, severe hemorrhage or sepsis, pulmonary preeclampsia or eclampsia, HELP syndrome, acute fatty liver, and TMA also here in pregnancy, and the TMA unknown mechanism also TMA. Also the common postpartum is here, and early pregnancy septic abortion, everything here. This is after 20 weeks, before 20 weeks, and after delivery TMA. Don't forget this. This is what this. And this is just a differential diagnosis for thrombocytopenia, either with schistocyte with the TTP, LDH, we need all this workup, or blast cells, peripheral blood smear, other differential diagnosis, or ITB, whatever. Just we can discuss this in separate presentation also. And this sign and symptoms for TMA already, you should just to increase your suspicion for TMA with AKI in pregnancy or after pregnancy. And with kidney biopsy and this fragmented blood cells we see in kidney biopsy already. We can discuss this also in separate presentation. And with complementary cascade already, and typical hemolytic uremic syndrome, just put in your mind. Among women with childbearing age, with a typical HS is present peripartum in around 10 to 50%. Just what I mean from this, don't forget this differential diagnosis of AKI, not only pre-renal or renal post. Don't forget this TMA or a typical HS reach about 50% for that. And if you think this your patient thrombotic microangiopathy with thrombocytopenia, anemia, don't forget to send this hemolysis screen, LDH, haptoglobin, schistocyte, and this patient with renal failure. If all this criteria is present, evidence of infection, Shiga toxin, Escherichia coli, or pneumonia, yes, infection linked typical HAS. This is a typical HAS if there is infection. If no, this send the Adam test 13. If less than 5, if yes, TTB, you need the plasma exchange here. If Adam test 13 is not is normal, this is atypical HAS, drugs, malignancy, genetic pregnancy is the most. Just take a photocopy for this slide, because AKI during the pregnancy, don't forget TMA, TTB, or atypical HAS. From this, you can diagnose by this. If infections, this is typical HAS. If no infection, Adam test 13. If less than 5, like that. TTB, if no, atypical HAS. Okay, I think it's simple to understand this, and we can discuss this later also. Don't forget take picture for this also. And the treatment already by plasmapheresis and successful after that. and maybe if typical HUS or typical HUS or TMA, just we can use also eculizumab. This is also studied. A medication pregnant women with CKD are given prenatal iron indicative erythropoietin as our patient vitamin D, calcium mimetic calcium should be discontinued, non-calcium based like sevelamer should be discontinued, aspirin 2 tablet at bedtime, calcium vitamin D. This is the main treatment for preeclampsia prevention. Kidney biopsy physiological diagnosis will change the management in pregnancy. The renal biopsy should be prepared in first and early second trimester. First and early second trimester, not the third trimester. Okay, when to do kidney biopsy in pregnancy, first and early second trimester. Volume assessment to keep your patient in euvolemic, not pulmonary edema or not volume depleted. Take care to assess your patient risk of volume edema because you're increasing the target weight and decrease the rate of filtration H dialysis. Expected date of delivery should be arranged with should be done planned by obstetrician to avoid deterioration of your kidney function and refractory hypertension. If your patient refractory hypertension and the kidney function should be delivered immediately. Non-steroidal should be avoided during the pregnancy. A woman with CKD over safe and effective contraception postpartum, as we mentioned before, progesterone. A renal transplant woman with renal transplant wait until their kidney function is stable at least 1 year after transplant. Cesarean section is a better with a senior, especially in kidney transplant patient, with a senior obstetrician or consultant better. Hemodialysis, as we mentioned before, women establish hemodialysis prior pregnancy. We need long, frequent dialysis, 6 times a week, each dialysis session around 8 hours. Women receiving hemodialysis during the pregnancy have dialysis dose prescribed account for residual, according to residual renal function, aiming pre-dialysis urea less than 12. Women established on peritoneal dialysis during pregnancy should convert to hemodialysis during pregnancy for better clearance and control. And this criteria for considering pregnancy in a renal transplant recipient, we have good health at least 2 years after kidney transplant. Now 1 year is visible if everything is okay. Absence of other contraindication, obstetric, stable allograft, serum creatinine below 180. No recent episode of acute rejection, no evidence on rejection, normal blood pressure. And I have already presented one presentation in pregnancy after kidney transplant. We'll present this presentation later. Absence of minimal proteinuria less than 500 milligram per day. No evidence of pelvic calcium, no obstructive uropathy or hydronephrosis. Immunosuppression prednisone, azathioprine, cyclosporin, MMF should be discontinued. In this area, disease is not sexy because anemia, fatigue, depression, and medication, antihypertensive medication, altered the body image. All this will lead you with depression also. All this will end by loss of desire for sexual function. Hemodialysis should be initiated in pregnancy when maternal urea concentration 17 to 20. Hemodialysis should be initiated in pregnancy when maternal urea is 17 or 20 millimole per liter, and the risk of preterm delivery outweighs those of dialysis initiation. Gestation, renal function, trajectory, fluid balance, biochemical parameters, blood pressure, uremic symptoms should be considered in addition to maternal urea concentration. And this protocol, you can take a picture and put in your management strategy for any pregnancy in your center, just for renal hemodialysis prescription and electrolytes, anemia, and dietary follow-up. You should take a picture for this and put in your dialysis center. And the role of obstetrician for fetal follow-up and plan for delivery, estimated delivery date, and follow-up in fetus like that by ultrasound. Take a picture for this also. And this management hemodialysis, pregnancy during hemodialysis, as we mentioned before, you can take a picture for this. Management strategy for intradialytic hypotension. We need your dialysis stable during the pregnancy because this will affect the fetal perfusion. Prescribed in the first slide, just review your medication, intensify your dialysis treatment, volume, status assessment, and anemia control, and dialysis composition play on this, all this. And then take a picture for this also. This will help you to control your dialysis patient. We mentioned to intensify hemodialysis benefit, blood pressure control, left ventricular also, hypertrophy control, arterial compliance, restoring the city, and everything. This will phosphate anemia, malnutrition, inflammation, cognition, fertility, quality of life, quality of sleep. All this will be better controlled with intensify your dialysis. Even pregnancy with peritoneal dialysis, just some patient already just abdominal fullness, discomfort, but already some patient ended by full-term delivery, and some also with preterm delivery, premature rupture of the membrane or acute peritonitis. This is a problem. Will be having better to shift your patient to hemodialysis. But better LBD is daily and without hemodynamic instability, no blood pressure up or down during the dialysis. And one case report of pregnant woman on BD reported in 1983, successful pregnancy at 33 weeks of gestation, intrauterine fetal demise at 30 weeks gestation. Larger early serious had mixed outcome, number of 14 patients. I think some patient doing well with the BD patient and some other not like that, but better if you can't control your patient, better to shift to hemodialysis. Polyhydramnios, excessive amniotic fluid collection from high urea if you're not dialyzed well, fetal solute diuresis, secondary increase placental BUM, urea nitrogen is high, and volume overload also. Please adjust hemodialysis prescription. Lupus or vasculitis, women with lupus vasculitis should be advised to wait until 6 months peak within to conceive or start planning for pregnancy, and to continue hydroxychloroquine. And you don't forget this in pregnancy, this message: women who has positive anti-RO-SSA or anti-LA-SSP antibodies should to do fetal echocardiogram, because this patient, most of them with congenital heart and heart block. You should follow this patient, especially if should screen any systemic lupus for anti-RO-SSA or anti-LA-SSP antibodies to follow your patient by fetal echocardiogram. Antiphospholipid syndrome, woman with antiphospholipid syndrome with history of conformant thromboembolic event with previous adverse obstetric outcome, excluding recurrent early vital loss, received low molecular weight heparin in pregnancy and for 6 weeks postpartum. Steroid, azathioprine, CNI, immunoglobulin, plasma exchange, all safe in pregnancy to treat lupus. Diabetes, woman with diabetes nephropathy, optimize the blood sugar, hemoglobin A1C with each lab and follow-up, and blood pressure control, proteinuria control prior conception. Woman with diabetic nephropathy continues until conception, but should be discontinued during the pregnancy. Reflux nephropathy, the prophylaxis for UTI, pre-pregnancy UTI prophylaxis be continued in pregnancy using agent known to be safe in pregnancy. Renal function in pregnancy is assessed using serum creatinine. Concentration as estimated GFR is not valid for use in pregnancy. Just follow up with your serum creatinine. Any proteinuria in pregnancy is pathological, no hyperfiltration. Put this in your mind. Any proteinuria in pregnancy is pathological, not hyperfiltration, until proved otherwise. Don't forget this management protocol for pregnancy from pregnancy clinic from Toronto. Pregnancy clinic protocol. Don't forget medication review here. Just keep a picture for you, for any patient, and put in your dialysis center for any pregnant lady for medication review at the dialysis prescription, diet, dialysis composition, anemia, volume status. Don't forget this. Summarize all this presentation. Take a home point. CKD stage 1 is associated with adverse outcome in pregnancy. Therapies to manage hypertension in pregnancy is not reduce the risk of preeclampsia. The most common cause of nephrotic proteinuria in pregnancy is preeclampsia. Postpartum persistent proteinuria, even past 3 months, or the past 3 months after birth, is common in preeclampsia. AKI postpartum is due to hemorrhage, sepsis, preeclampsia, HUS, TTP. Don't forget this. AKI postpartum, secondary to hemorrhage, sepsis, preeclampsia, HUS, TTP. The first line of therapy of atypical HUS peripartum is plasma exchange. First line of therapy for atypical HUS peripartum is plasma exchange. This is our reference from presentation of our Dr. Michelle. This is a famous and mentor for me in pregnancy clinic and the GN clinic. And from up-to-date Brenner directors, seminars in Jason 2009, Advanced Chronic CKD 2013. ويا رب تكونوا استفدتوا شيء نفيد بيه مرضانا في مرضى الغسيل، وخاصة لو حد نفسه يخلف طبعا من المرضى، وكل واحد ليه نفس يعني. ربنا يرزق كل محروم إن شاء الله، ويتمنى تخدموا بيه مرضانا وتدعوا لنا دايما، ولا تنسونا دايما بالدعاء بالبركة في الصحة والوقت والمال والأولاد، ونسألكم دعاء بالصحة والعافية. ولا تنسوا دائما الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. ونلقاكم بفيديو قريب إن شاء الله، ومحاضرة أفضل وأحسن بإذن الله. وأترككم في رعاية الله وحفظه، والسلام عليكم ورحمة الله وبركاته.